The first speaker will be known to many people in the audience, and this is Professor Jörg Klepper, and he's going to speak to us today on the power of ketogenic diets in GLUT1D deficiency and metabolic disease.
Well, thank you very much for this kind introduction and the invitation to speak here. Hello to everyone. My job is to talk about the power of ketogenic diets in metabolic disease, in particular with special emphasis on the GLUT1 deficiency. And why is that interesting? Well, it is exciting because when you look at 2009, when you enter the search term ketogenic diet, there were 800 hits. When you do that today, there'll be well over 2,000. And the same holds true for GLUT1 deficiency syndrome. So really there is an increasing interest in the diets and in this particular disorder. And my job will be to outline what's happening in terms of ketogenic diets and other treatments that affect these metabolic states. As you can see here, we have the ketogenic diet and epilepsy, so I'll briefly touch that, and then we'll carry on to our main topic, which is ketogenic diet and the metabolic diseases. There's not one ketogenic diet anymore. We have lots of ketogenic diets. We have oral ketones, we have ketone esters, and I'll run you through that in the next minutes. When we talk about a ketogenic diet, very basically what you do is you restrict carbohydrates, you allow enough protein for growth, and then you have a high-fat diet that mimics the metabolic state of fasting. You produce a ketosis, and this ketosis somehow works anticonvulsive. Now, of course, in practice, it's much more complicated. As you can see here, there are several mechanisms that will result in the anticonvulsant action. Among them, you'll have mitochondrial biogenesis that's elevated. You'll have more energy in the cell. Neurotransmitters, especially the inhibitory neurotransmitters, will be affected, like GABA and glutamine, and it will stabilize the synaptic function. So a lot of processes contribute to this anticonvulsant effect. Now, the main indication for ketogenic diets is intractable childhood epilepsy. The definition is when 2 or more adequately used anticonvulsants have failed, then this is a valid option. And as you can see, the majority of patients treated with ketogenic diets have epilepsy. Does it work? Yes, it does. Here you can see the Cochrane reviews. There was a first Cochrane review in 2003, no randomized controlled trials, no patients, and the reviewers concluded that it's a possible option, but nothing serious. In 2012, there were 4 randomized controlled trials and almost 300 patients, so they decided it could improve seizure control, and in 2016, there's a third review, and they found 7 randomized controlled trials with more than 400 patients, and their conclusion was that they show promising results and it's a valid option. So we do use the ketogenic diet for epilepsy. Now, my main topic is how do you use it for metabolic diseases, in particular GLUT1 deficiency syndrome. This is the minority of patients treated with a ketogenic diet, but very important patient because in most of them it's the treatment of choice. When we talk about inborn error of metabolism and you read a paper about some metabolic disease treated with a ketogenic diet, you have to be aware that in some patients it is not the underlying pathology that is treated, it's simply the symptom epilepsy. So it has basically nothing to do with the metabolic defect, it is simply treating epilepsy. And as you can see here, there are a number of inborn error of metabolism, but the patients reported, the patient number is small. The main issue I want to talk about today is where you really treat the metabolic defect, the pathology behind the disease, and I'll explain that at the disease of GLUT1 deficiency. There's mitochondrial disorders like PDH deficiency, respiratory chain defects that fall into that category too. Metabolism is very complicated, and you know much more about it than I do. So I just want to carry on to give you a very simple scheme of how I understand brain energy metabolism. You have the brain, that's the blue box, and you have glucose that comes in, and by glycolysis it will be broken down to acetylcoenzyme A, enters the citric cycle, and yields energy. Now, when you're fasting, you break down your body fat. Fat can't enter the cell. It has to be transferred in the liver to ketones and serves as an alternative fuel to the brain. It enters via a different transporter, the MCT1 transporter. The ketogenic diet basically follows the same idea and mimics the metabolic state of fasting. It just exchanges the body fat for nutritional fat, and you can carry on with the state of fasting. Now, having talked about GLUT1 deficiency, where you can't get glucose into the cell because the transporter is broken, and PDH deficiency, where you can't transfer pyruvate to acetylcoenzyme A, you can very, very clearly show that the ketogenic diet and the ketones bypass this defect and refuel the brain by offering ketones rather than glucose, and that's the idea behind it. The diagnosis of this condition, consequently, is done by a lumbar puncture, and the biochemical hallmark of the disease will be a low CSF glucose because the transporter won't get enough into the brain. Also, the CSF lactate is always low to normal, and that's important when you want to see whether the low glucose is due to any other reason. So check the lactate and see if it's really low. I'm often asked, how low is too low? What is actually the threshold? And there's a very nice paper in 2013 that shows that you're around 20 to 50 milligram per deciliter in the patients on average, and you can see that there's also an age-dependent raise of the CSF glucose when you grow. Of course, we know that it's a monogenic disease, and you should look for mutations. They are usually autosomal dominant mutations, de novo mutations. And in fact, I always advise people to do both the biochemistry, the lumbar puncture, and the genetics to really make the diagnosis. Once you have these patients, what do they look like? They have a complex phenotype with developmental delay, with epilepsy, and a movement disorder. And the classical phenotype will show you all three of these symptoms. But you can have any variation. You can have a child with just absent seizures, and it might be GLUT1 deficiency syndrome. You can have a child that has just a movement disorder, nothing else, and it could have GLUT1 deficiency syndrome. But because the treatment with a ketogenic diet is so intriguing, you should look for these patients, and people do this, and the number of patients is steadily increasing. What happens? This is when you administer the ketogenic diet. This was the first patient we diagnosed in Germany. It's a 4-year-old girl. She had about 300 seizures a day. She couldn't talk. She couldn't walk. She was very ataxic, and she has microcephaly. And this is the state before the ketogenic diet. And after 4 months on the diet, you can really see the difference. Seizures stopped the very next day. The child began to talk after a while, and you can see that she's much more stable and the movement disorder improved. Now, this is the classical phenotype and a classical reaction to the ketogenic diet. So we thought, wonderful, we really have a perfect treatment here. And then, as our patients grew older, we recognized that there is more to the story. It's not just the seizures and the developmental delay. We recognize that we have several ketogenic diets where we can play around with in terms of compliance, and we have to evaluate them. We found that puberty, as they grow older, really is a problem because they developed something we call paroxysmal, sudden, dystonic events. And these events, I'll show you a video in a second, really don't respond to the ketogenic diet. We have no idea why they don't, and we don't have a treatment yet. And then, of course, once they come into puberty and adulthood, there's a transition to adult neurology, there's the worry about side effect of a long-term ketogenic diet, so we have plenty of work ahead of us. This is a girl, an English girl actually, and she is 10 years old, and she has what we call these paroxysmal events. She is very mildly affected. You can see that when she walks, this is her normal state, you wouldn't really think that she has a movement problem. She's on the ketogenic diet, everything works well, she's mildly affected, and then this was after a walk in town in the hotel lobby, and she has these choreotypic movements which she can't control. It's obviously very distressing for her. Mom tries to help. She can't stop it. It lasted for about 15 minutes, and she kept having these episodes, sometimes associated to exercise or cold, but we haven't really found the trigger factors yet. And as I said, they don't respond very well to the ketogenic diet. So there's a challenge for us. As these patients grow older, we see that the phenotype of Glut1 becomes more complex. So if you see a patient like this with paroxysmal dystonic events, think of Glut1 deficiency. How do we treat them? This is a regular diet on the bottom, and then the classic ketogenic diet on top. And now I told you we have several ketogenic diets now. We have the modified Atkins diet. So with the increase of carbohydrates, which is the red part of the slides, you get better taste, so you improve compliance, but on the expense of ketosis. And the question is, how much ketosis do you really need? Right? We agree that the classical ketogenic diet and probably the modified Atkins is a good idea for Glut1, but not something like glycemic index diets or even stopping the diet. Why? Because especially the developing brain needs more energy than you and me, 3 to 4 times more energy than the adult. So what you want to do is you want to start the diet early, and there's no problem starting it in an infant where you diagnose Glut1, and you want to maintain it into puberty, into adolescence, and then see how things go on. Then it's an individual decision on compliance and how the patient, how the problems the patient has. Just briefly touching the respiratory chain defects, this is not as straightforward as the ketogenic diet in Glut1 deficiency syndrome or PDH deficiency, because it has been triggered by the paper in 2007, 14 patients, most of them complex 1 deficiency, and the Korean group reported that 50% of these patients became seizure-free on a ketogenic diet. Didn't work in Lee syndrome, but was otherwise well taken. And a year later, there were another 24 patients, and they concluded a ketogenic diet produced seizure reduction and global functional improvement in 75% of these patients. So obviously, this seems to be a treatment that might work, but the pathophysiology behind it is very complex and would require a separate talk, and we'll hear more about mitochondrial diseases afterwards. Having said that we have a lot of ketogenic diet, the next approach is you have metabolic diseases where you could endanger the patient by ketogenic diets. Like if you have glycogen storage diseases, you couldn't introduce a ketogenic diet there because the patient will become very hyperglycemic, and you might really endanger him by fasting him, turning or switching on the ketosis. So why can't you give the ketones orally, directly? And there's another disease which has to do with fatty acid oxidation. If you can't break down fat to ketones, again, this would be a contraindication for the ketogenic diet. But why not give the ketones directly? Well, it has been done. Lancet, 2003, in MADD deficiency. This is a disease causing cardiomyopathy and leukodystrophy. And the index case was a 2-year-old boy with rapid leukodystrophy. He was paralyzed within 4 months, and they administered 3-hydroxybutyrate sodium salt. The outcome was that he improved within weeks, and after 2 years, he was able to walk independently. And you can see in the images that it improved over 9 months. Now, what's the problem with oral ketones? The oral ketones they used, 3-hydroxybutyrate, comes as a racemate with a D and an L form, but only the D form can be metabolized. So you always have to give twice the amount of this ketone salt because 50% in the L form can't be metabolized. It's a sodium salt, so you have problems with the kidneys to excrete the sodium. It would be much nicer to have a potassium salt, but that's not available. So you have to be afraid of a sodium overload. And finally, and that's a legal issue also, it's not on the market. It's not commercially available. You can get it for your lab, from your lab supplier, but your lab supplier will become very nervous if you tell him that you want to use it on sick children. So all these legal issues and intention to treat studies, all that comes in. So it's not very easy to do that. So why not take a different approach and produce artificial ketones that don't have these problems? And there are ketoesters, which we are, at the moment, there's a big hype about that and the way they work. What they are C7 artificial ketones, and when you link 3 of them together, you get 3-heptanoine, 3 times C7 artificial ketones, and they will enter the citric cycle just as ketones do and produce energy. And funnily enough, as a side story, the Navy SEALs got quite interested in that because when they do their diving, they use rebreathers, so they don't produce bubbles, and they breathe 100% oxygen. The problem with 100% oxygen is that they get seizures. They are prone to seizures, and when you are 30 meters under the water fighting, it's not a good idea to get a seizure. So the Navy SEALs thought, can we get some sort of supplement to give to these divers so they'll be protected from seizures and they can stay a longer time underwater? And they thought of ketone esters, and there are still research going on that way. Now, what are these ketone esters? Triheptanoin is an artificial ketone, as I said. It's been used as a tracer for butter in the European community, so all of you have been eating it. Maybe in the future the British won't, but at the moment it is a tracer. But of course you would use it in a much larger scale in patients, not milligrams or micrograms, but really gram-wise. It's liquid at room temperature and tastes indifferently. Now, as the ketones are metabolized, even carbons, and I told you they produce energy, the thing about the ketone esters is that they have the odd carbons because it's a C7. So you don't only have the even carbons, you have the odd carbons, and the odd carbons have a so-called anaplerotic effect. So on top of yielding energy, just as the ketones do, they fuel the citric cycle, and that's called anaplerosis, and that's been shown in a review of 15 years experience on a fatty oxidation disorder just recently that it works with anaplerosis. And as I said, it's been shown in mice, in Glut-1 deficient mice, that it helps and it works. So we have a study, and some of you might have heard about this study. It's basically run by a company, Ketogenic it's called, and they have a randomized double-blind placebo-controlled trial that's up and running, and they have a 6-week baseline where they evaluate these patients. Then they have 8 weeks either placebo or the C7, and then an extension period where you can still get the C7. So this study sounds quite convincing, but there are sort of some red flags I want to share with you. One of them is that you can only enter children that are not on the ketogenic diet, because I think it's unethical to stop a ketogenic diet for a trial like this. You don't know if it even works just as well. On top of that, even if you diagnose a patient with Glut-1 deficiency, you want to put him on the treatment on choice, which is the ketogenic diet. If you enter him into this study, he'll have 3 months of non-treatment, the 6-week baseline, and possibly the placebo arm, and that's debatable. And then, of course, with the extension period, this period of not using the treatment of choice might even be longer. Parent support groups are also concerned whether this triheptanoin will be freely available as a food supplement, or whether it will be a drug that will be expensive and needs to be prescribed. And of course, we wonder what happens with the data. Now, end of last year, there was a proof of concept publication with 8 patients, and they showed that after a 6 months treatment, these paroxysmal events I just showed you in the video with that girl improved by the triheptanoin. So this is encouraging data, but obviously it has to be taken with a pinch of salt, and we have to wait and see what the study will yield in the end. There are other studies up and running. This is Dr. Pasquale in Texas. He sets up another triheptanoin study. And whenever you have a patient with Glut1, please enter him on the website given there, because there he can register in an online questionnaire, and then that helps us to create an independent data bank associated with the Texas University, and it will answer the unanswered questions we have, like how many patients are there in the world? What's the clinical classification? We still haven't got one. The phenotype-genotype relation and the non-responders to the ketogenic diet are open questions. The long-term adverse effect of ketogenic diets, if the Glut1 deficiency affects other tissues, not just the brain, what happens in puberty, as I told you, the transition into adult neurology, and triheptanoin. So there are a lot of open questions we need to tackle. In summary, I have talked about the classical ketogenic diets, and you have Glut1 deficiency and PDH deficiency as the 2 diseases where it's a treatment of choice because it serves as an alternative fuel. Then you can use ketones for MADD and glycogen storage disorders, but careful and only a few reports. And then I talked about the ketone esters as the next promising idea with the anaplerotic effect. Taking sort of a step back, in the overall view, the ketogenic diet is very much investigated now for its neuroprotective mechanisms in Alzheimer's disease, Parkinson's disease, Huntington's disease, and this would really be a breakthrough if the adult neurologist would be interested in the ketogenic diet, because then the research in this topic would be fired up. Practical issue at the end. If you have patients and you want to know who is doing a ketogenic diet in your country, this is a website by Eric Kossoff from Johns Hopkins, and he regularly updates it, so you can just click on your continent and then click down to the country or the town and see who is offering the ketogenic diet in your country. If you do it, just drop Dr. Kossoff an email and he'll enter you in this list. I'll be open for questions. Thank you much for listening. And if you do have questions that we can't cover in this big audience, please drop me an email. I'll be happy to answer. Thank you very much.
Thank you very much indeed. You never ever fail to bring new information. That is really, really fantastic, really comprehensive. Now, questions. We've got 5 minutes for questions.
Yes, thank you for this very nice overview. However, I do not agree with your statement that glycogen storage diseases are a principal contraindication for ketogenic diet. We have made excellent experience with patients with glycogen storage disease type 3, 3A. We had one child with severe cardiomyopathy. We put him on a modified Atkins diet, and his cardiomyopathy almost disappeared. So the pathophysiological principle is probably using ketones as an alternative substrate. If you offer a lot of carbohydrates, you will also induce hyperinsulinism, right. And then there will be some energy depletion of the muscle. And so we, as I said, we made excellent experience. And so we had some hypoglycemia in the beginning, but the patients slowly adapted to it.
So you would recommend it, and I think I agree that contraindication is putting it too strong. With the modified Atkins diet, and especially with the avoidance of fasting. When you introduce the diets, you don't fast anymore. You usually just switch the food into the ketogenic diet food, and there's no need to fast the children. Maybe that is that helps to sort of do that, and I put it in my talk particularly because it has been reported, but it's still a few reports, and I think you have to be aware of this complication of hypoglycemia.
Different in glycogen storage disease type 1,
okay.
which has a stronger tendency towards hypoglycemia.
Okay. Thank you.
Thank you. Okay, thank you. One more question over here.
Elena Petropoulou from Birmingham Children's Hospital. Thank you, Dr. Klepper, for this insightful presentation. May I ask you, when you use the C7, which ketogenic diet did you find was the most effective? Was the 4-1, 3-1? Did you look for which one to use?
I haven't used the C7 yet. This is the study by the study of Ultragenics I showed you, and there are other studies will be coming, but I'm not using C7, so I haven't done it yet. There might be a study where you want to add C7 to a classical ketogenic diet, just like you suggested. I think that would be a very good approach to enter the children that are already on a ketogenic diet and see what is the additional effect.
Question.
Thank you very much for your nice talk. Just a question now. In Greece, we have 8 patients. You know already the 2 of them. 2 of them have normal glucose in CSF.
Yeah.
So my first suggestion, which patient have you look for GLUT1 defect? And then what about adults?
Right.
Apropos to inform you, the one with the diagnosis in the age of 11, now 16, doing perfect.
Yeah.
He has no seizures,
Right.
never had seizures, but mentally it's amazing. He can speak, he can now go to school slowly, it's amazing.
So answer to the first question, you find every combination. You do find a patient that clearly has clinical GLUT1 deficiency in response to the diet, but has a normal CSF glucose. I can't explain it, but it has a pathogenic mutation, so it's a patient. There are patients reported that have clearly CSF glucose low, but no mutation in the SLC gene and responding to the ketogenic diet. So you can have every combination, and I don't have an explanation for everything, but that's why you have to do the lumbar puncture and preferably the genetic as well. Second question with the adults, we haven't understood the GLUT1 deficiency in adulthood yet. It seems to stabilize over the years, and then it depends on whether they were treated or not, which mutation they have, what's the phenotype like, and as I told you, there's no classification yet. So the best you can do is go to the data bank, enter your patient, and then eventually when we have the bigger numbers, we can make sense of what it looks like in adults.
Very much.
I have a off-the-wall question for you.
Right.
Is there any relation to the heptanoic compound, and can it be can it interact with monoheptulose? Because monoheptulose can affect insulin secretion and glucose metabolism.
I have no idea. Sorry, I can't answer that question, and I can't even tell you whether someone has looked into that. So it would be worth, the person to talk to about that would be either Dr. Pasquale, who is the one in Texas, or the people who just published their patients on the 15 years experience on it.
So it's really off the wall.
Yes, I'm sorry, I can't answer that.